Thank you very much, Dr. Peter and Dr. Junaid, for really exciting presentations. I have a ton load of questions. I'm going to go through one by one. So I'm going to alternate the questions. So I'll give you the break. And we'll try to get as many questions as the time allows. For Dr. Peter, the first question we have is that there was a publication in 2018 about focal intestinal perforation in LISA for babies under 26 weeks. I know your study in MIST did not show any difference in intestinal perforation between the control and the MIST group. Why do you think the difference in between these two studies? Is it related to sample size? Is it related to the surfactants? Can you comment on this?
Yeah, I'm not sure is the honest answer, Aiman. I don't know. There's sometimes we get random effects. Spontaneous perforation occurs occasionally, doesn't it? We seem to have many epidemics of it, and then it goes away. I suspect that that's the case here. It's a random effect. We will watch it in future trials, but as you say, we found no evidence of it in our study, and I'm not aware that other studies have found a similar problem. So it's something to file away and to keep an eye out in future trials, but I don't think it's something that we need to particularly worry about.
In our guidelines that we did in our hospital, we try to start with MIST in the babies over 32 weeks. So just to kind of be on the safe side, just to start with. But you know, since you didn't find any difference, what kind of surfactant do you use for MIST?
We use CuraSurf because it's a small volume. And like you, while we were waiting the results of the trial, we started trying it in our more mature babies and got a feel for it. Those babies perhaps are a little bit more stable during the procedure. Also, if you let them get big enough, they will fight you a little bit more. So that's a problem. But I think that's a very sensible approach to try it on the bigger babies and then work down as you become more confident with it. We did find some issues when we started to roll it out to our junior staff, and we were much less confident they were putting the catheter between the vocal cords, and we've moved back to restrict the people who administer the surfactant to the more experienced fellows and consultants.
Great, thank you. Question, Dr. Junaid. What is the long-term adverse effects of inhaled nitric oxide?
As I mentioned in few of the studies, especially if the babies are less than 1,000 grams, the neurodevelopmental index at 18 and 26 month follow-up showed that there is a decrease in NDI. Not only that, the immediate effect of grade 3 to 4 IVH and PVL is higher in less than 1,000 gram babies if they use the INO. So this is just mention the evidence which I showed you.
Okay. Question to Dr. Davis. During MIST, should we put an open orogastric tube in the stomach during installation of surfactant?
We don't routinely do that. I guess most of these babies will have a nasogastric tube in because they've been on nasal CPAP. We wouldn't put one especially down. It's a useful way of diagnosing whether the operator has put the catheter between the cords or down the esophagus. If you get the same volume up through the nasogastric tube, you can be pretty sure they've picked the wrong hole. But yeah, so we wouldn't put one down specifically for it, but most of our babies would already have one down.
Thank you. Dr. Junaid, how do you explain the benefits of inhaled nitric oxide in pulmonary hypoplasia, knowing that the vessels are not formed?
Yeah, so as I mentioned, that pulmonary hypoplasia didn't show any benefit, but with the pulmonary hypoplasia plus the PPHN, persistent pulmonary hypertension, that is a benefit for that. So this is answer the question, is the answer in the question, because in pulmonary hypoplasia, the vessels are not that developed. So they don't have the PPHN, but if they have the PPHN plus the pulmonary hypoplasia, yes, there is a benefit.
Thank you. Dr. Peter, what is the best type of catheter to use in MIST?
Yeah, we used the vascular catheter for a long time because that was all we had available to us. That was a size 16 angiocath, and that's perfectly fine. We were a little bit nervous that the edge of that, the end of that catheter was a little bit sharp, and we worried about causing some damage to the trachea, but we didn't ever see that. But nowadays that we have the purpose-built catheter, the Lisa cath, we would preferentially use that. It's got a rounded, beveled end, and we feel more secure there. And it's got markings on the catheter to guide you to put it at the correct depth. So that's what we'd be recommending.
That's good. I think that you answered this in a question in your presentation about sedation during this. I think you said that you use Cypros. Anything else? Anatropine. Anything else you use?
No, when we started this process, we were quite concerned, and people said, look, if you're going to put a laryngoscope down a baby's mouth, that's going to be uncomfortable and you should sedate or even muscle relax the baby. But we thought that was sort of defeating the purpose. And so we tried with just some sucrose and atropine. The nurses, who are the guardians of our babies, seemed happy that we weren't disturbing them too much. It sort of adds weight to what I was saying about using an experienced operator who can do the job quickly, like the young lady in the video there, minimising the distress. And that way we rationalise just using those measures that I described.
Dr. Junaid, I think you mentioned this. What is the risk of IVH in using the INO for premature babies? I think you mentioned this.
Yeah, I mentioned it. This is more in the less than 1,000 grams, the grade 3 to 4 IVH.
Do you have a percentage?
I don't have the percentage, but it is a statistically significant.
Question for Dr. Davis. What about vitamin A used to reduce the risk of PPD?
Yeah, that's I didn't get round to that. That's an interesting question, isn't it? And vitamin A is definitely shown to reduce risk of BPD. There was a large trial done in the US. The problem with that trial was it was intramuscular injections of regular intramuscular injections of vitamin A, and I think the public voted with their feet and said that the pain of those injections is not worth the small reduction in BPD. The benefits, we certainly include vitamin A as we do all other vitamins, essential vitamins in our day-to-day care of these babies, but the intramuscular doses have not really taken off.
There's a question about inhaled or aerosolized surfactants. Anything about that?
Look, that is the holy grail, I guess you might say. If we could get that right and not have to put laryngoscopes down babies' throats, then that would be wonderful. There have been a couple of small trials in bigger babies that have shown an effect, but in treating our little babies, we're still waiting for evidence that it's going to be effective. There are some new nebulizers being developed that we think might optimize that droplet size. So the problem has always been the droplet size was either too big and the surfactant would precipitate out before it got to the lungs, or it would go all the way into the alveoli and then come straight back out again. But as the nebulizer technology gets better, it may be in the future that this is a great treatment, but not just yet.
I think that the technology had to evolve around having aerosolized surfactant that's small enough to go to the alveolar part of the lungs and not precipitate in the airway, and not heated to kind of make it the surfactant not useful.
Exactly.
So that's the technology they're working on. So the questions, I have another question about sedation that probably just somebody joined in. Just an update on, we have a 3,652 colleagues registered now, and among them 1,468 are logged on right now. So I'm getting a lot of questions, but I don't have, we exceeded the time and the break.
Just one minute, I have some question. Peter, Very welcome again. I have a question about the release. I did in my previous job, and we did in a very small baby, even in the quadruplets, and they are 26, 27 weeker, about 800 to 1000 gram each, and none of them require ventilation. So I really have a very good experience with them, and not only those, I have a group of, let's say, these type of maybe about 40, okay, and I have data for that, and only 3 of them fail CPAP after that. So really, what do you think? It is going to be the future? It is going to be the standard of care? What do you think at this point?
I think that's right, Junaid. We're very confident now. We were always waiting for the result of this trial to reassure us, but you're ahead of us, and I think this should be standard of care for babies on CPAP. It just gives us a really nice way of avoiding endotracheal intubation for those babies. I think particularly 25 weeks and above. I'm not sure that we're going to be able to keep the tiniest 23, 24 weekers off the ventilator, but the bigger babies, yes, I think it's very well worth a try.
The other question, sorry, Aiman, I'm just taking one or two questions. The CuroSurf you are using, but you know that CuroSurf, right now we are also using a CuroSurf. We have this legal document because of the Islam and all those things. But let's say if you have not available CuroSurf, or the parents refuse to use the CuroSurf, with that technique, do you have experience with other surfactants?
We don't, Junaid, but I don't think that's a deal breaker. I think it's probably technically a bit more difficult if you're using a volume of surfactant that's greater. But look, I think it's, having shown it works with CuroSurf, I don't think there's any reason to think it won't work with the others. It might just be a little bit more clunky. It might take a little bit longer to administer. Mm-hmm. You might have a higher rate of desaturations during the procedure. But I don't really think it's the surfactant that makes a big difference.
And last but not least, at least I am very patiently 2 things: to meet you in person and your plus trial. Plus trial is going to be game changer if it is going to be available.
We hope so, Junaid, and even if we see half of the benefits that our Taiwanese colleague demonstrated, it will be worthwhile. But as I made the point all the way through this evening, we've just got to be really cautious. Things that sound really good sometimes turn out not to be good. But I'm very hopeful that the plus trial will represent a major breakthrough.
I got a signal from the organizers that we can go a little bit longer with the questions because we're getting more questions as we go. As long as it's not too late for Peter, it's going to be late in the evening for you.
The sun has just gone down. We're okay.
We have a question about established or severe PPD. We have a lot of strategies to prevent, but how about strategies in treatment of established and severe PPD?
Well, nitric oxide doesn't work. Look, I don't have any magic. We don't have any magic. We use as much steroids as it takes to get these babies off the ventilator. We will occasionally use vasodilators if we've proven the baby has pulmonary hypertension. But they're very difficult, aren't they? And I'm afraid I don't have the magic wand to say, try this. We've started some trials on stem cells, and we're learning a little bit about the pitfalls, about the administration of them. There's a long way to go before they're an established therapy, but perhaps that's where we're going to end up, stem cells or exosomes therapy to try and allow the lung to regenerate more normal morphology.
Thank you very much, both Dr. Davis and Dr. Junaid, for a really nice session to start out our conference. There's a lot more to come. We're going to take a short break. And thank you, Dr. Davis. We'll hope to see you in person next time.
Yeah.
Inshallah. Inshallah.
And I hope, Peter, if you can join at least our ventilation session. This is tomorrow in the morning, so your evening again, if you have time. So I can ask more questions to you.
Look forward to it.
Okay.
Thank you very much, both. And we're going to take a break for about 10 minutes, and then we will get back with the second session. Thank you very much.
Thank you.
Thank you.